Yeah, it was truly amazing information. So thank you. And I can't wait to post this event. Because honestly, it's just been a day of just, I would say, mind-blowing information. And it's nothing like having a forum like this where we can share information and just see how powerful women are doing amazing and innovative things to improve health outcomes and access to care globally. So more to come. This is the start. This is the start. Okay. So next, oh, love this. This is a perfect topic for this event, digital happiness and freedom. So we are going to hear from Angelica Baptista Silva. Dr. Angelica Baptista Silva, PhD, is a distinguished Brazilian scholar and public health researcher recognized for her leadership in digital health, telemedicine, and health equity. As a senior researcher at the Oswaldo Cruz Foundation, she has directed nationally relevant initiatives that strengthen Brazil's unified health system through innovative digital strategies, capacity building programs, and evidence-based policy development. Her work spans the evaluation of telehealth services, digital health literacy, and gender-focused health interventions with a sustained commitment to improving care for vulnerable and marginalized populations. An award-winning scientist and widely published author, Dr. Silver contributes to international research networks, scientific committees, and editorial boards, advancing the global conversation on technology-enabled public health. Angelica?
Thank you. And hello, everyone. I'm Angélica from Brazil. Uma saudação para a Latinoamérica, para a lusofonia, para as mulheres cubanas que fazem saúde digital. I'm here in this pleasant meeting with these intelligent women to talk about digital happiness and freedom. Are you seeing?
Yes.
Thank you. Right now, we are seeing on this slide an image that represents what we all look at and look for when we pick up any gadget, any electronic device in our hands, right? Every time we pick up a device, we're looking for something, looking for someone, some idea, looking for happiness, looking for something that brings us happiness. In this case, we are looking at an image that brings an idealization of a romantic love between young people. But it could be someone looking for knowledge. It could be someone looking for a match. It could be someone looking for approval. It could be someone looking for a group, but we are always there looking for something on the other side of the screen, usually looking for joy. What's up? What does this mean for the health sector when we lose joy? It does not consider that on the other side, user is looking for joy. And freedom. Where's the freedom? The freedom that we have been looking for since we are born. What does it mean in the digital ecosystem that we are always concerned with other things like when we build a medical web? If we speak as a social scientist in terms of freedom and we make a system centered on the human being, what's freedom in our ideas of freedom that comes from the time of the French Revolution? What is freedom today within a digital world? Has anything changed? Have you ever wondered in the rush of everyday life, am I asking too much, right? What's freedom for our civilized process with digitized world where we work with machines, with world governed by machines, and that care where caring depends on digital? What does freedom mean? So I wanted to use this image and allow my friends to use a metaphor as if we were at a rock concert. Surely you have all been to a concert, or you have children, adolescents who go to concerts with your other friends. There are a lot of young people together, gathered like in this image that you are seeing on this slide. And usually they carry their smartphones. Many records and broadcast live shows on their smartphones. And we see this contradiction today. Many people don't have fun and want to capture that moment and broadcast it live instead of having fun. I think my finger it's nervous. My finger is nervous.
No worries.
Where's okay. I think that this image, this moment reflects such digital freedom. We have the freedom to be living in that moment, feeling the joy of listening to your favorite artists, to be with your friend, listen to the music that you like it's live. You are feeling that to face, that is a moment that you cannot pass on to the other, because the face-to-face is a moment completely different from what you are going through than a small screen to the other person. At the same time, you can also broadcast it on the screen and try to share it so for someone else to experience it with you, right? Anyway, this is called freedom of choice. It's a kind of digital freedom if you think about it. So I like this metaphor. It's an experience of digital freedom. It's an experience that we can transmute to our area, to our health area. An experience that I think we need to think about within the hospital, within the clinic, and within the entire care process. As health workers, as people who teach how to care, and then I want to talk about the classroom. I put this photo, which is the photo I took from a course I took within my institution from the Oswaldo Cruz Foundation, within Professor Matt Hoffman, who is a researcher and from Denmark. She spoke about design within hospitals, design from health apps, working on the issue of power and the patient as the center of care. In the photo, you can see the students who were in the activity discussing the application they were going to create to solve the problem posed in the practice experience. She uses some techniques to reinforce precisely the insertion of patients in the design of applications from the beginning of the conception of computer solutions. Matt is a head nurse with Diabetes Care Center and has developed applications in many areas, and she works on several very interesting research techniques. And even with Lego dolls like this, to disarm a series of prejudices among medical teams, very professional and horizons, knowledge, and try to establish dialogues between different contexts and people. That's what we need to start working on, thinking about different cultures, contexts, and classes, and considering intersectionalities for a future for humanity. That's what we need to start working on, thinking about different. You are seeing in this slide a model where situations are created, problems in which situations are simulated, where perceptions, emotions, and issues are presented in a space where everyone is equal: the patient, the professional, the head of the session, the doctor, the psychologist, and the nursing technician. Everyone has the same voice. Everything can be done there. People give their opinion on any clinical case, anything, freely. From there, you get the exemplary case, all the specifics that can help create a slightly more accurate application, any application. Because we know today, with the number of devices we have in the digital ecosystem, that this is not just a smartphone. You can see that in this photo of the course, most of them are women. In fact, in the fields of health and care, the predominance is of women. However, men are present and usually in positions of command. This is the matter of men and women. Care center on the human person is an issue in which more and more men have to be with us in this. Thankfully, they are present. You are seeing a man there's who is a computer professional and made the course. He made an important contribution for the group. That's because we must be together in this process, especially because work is ours. We need to think of health as a user-centered work process, a process that combines joy, that combines freedom of choice, and this freedom of choice is a freedom that involves the literature of patients. The health professional needs to have the sensitivity to know and have a tool to know how much the patient can use the digital ecosystem. He must also know to what extent he can use digital tools according to the digital literacy that this patient has. This patient may have a great degree of vulnerability, not having enough literacy to manage the digital ecosystem at his disposal. That is situations such as he can no longer type on a screen, or he can no longer remember his ID number, how he self-manage, he self-manage his health and care. So will he be excluded from his treatment because he can no longer enter his ID? How is that? What are the alternatives to enter a fully digital hospital? Like we saw today, alternatives need to be available. Face-to-face cannot be completely replaced as marketing preaches on social networks. Finally, a new radical enlightenment emerges that the Spanish philosopher Marina Garcés has spoken of in her lectures. I suggest that you pay close attention to the words of this young woman. And look, tacit knowledge will not be replaced. The joy of living and you human is there. The feminine and techno-feminism are there to endorse this at all times. Human rights, the colonial studies are also very much to reaffirm these issues. So that's my message. The Women's Group of International Societies working with some questions and issues. We are always organizing seminars, some movements, and we invite you. We will making a gender equality plan and a global mapping focused on the women's labor market in digital health. We count on your participation and affiliation in society. Thank you very much for your attention.
Thank you. I see claps in the chat. I appreciate your presentation because it does remind us in the midst of this digital health revolution that at the center is what? The person, our humanity. And those things are non-negotiable and really important when it comes to the consideration and successful implementation of what we do. So I thank you. Very different twist, and a much needed one, honestly. We need to be reminded of that. Does anyone else have any comments? I'm looking in the chat. Really good presentation. Next presentation is entitled Breaking Silos, Women Leading the Data Revolution in Healthcare. And our speaker, our presenter is Keisha Wilson. Keisha Wilson is an author and the founder and CEO of KW Advanced Consulting, a minority women-owned enterprise and economically disadvantaged women-owned small business certified professional with nearly 30 years of experience in healthcare. A seasoned speaker at the HealthCon National and Regional Conference, Keisha's career spans roles including outpatient coding specialist, CDI specialist, compliance operations manager, interim compliance director, and consultant. An expert in compliance and revenue cycle management, Keisha specializes in risk-based audits, EM auditing, multi-special coding, telehealth services, and risk adjustment HCC education. She has developed and implemented comprehensive training programs for organizations of all sizes and is an approved instructor for KW Advanced Consulting, AAPC VILT, and New York City College of Technology. Beyond her professional roles, Keisha serves on the board of directors for an outpatient mental health clinic and contributes to telehealth and compliance committees. She is also chair of the Healthcare Disparities Working Group for the ISfTEH, and she serves on the advisory board for the Nurses Pub and the HIM department at South New Hampshire University. A published author, she writes regularly for KW Advanced Consulting and AAPC, the magazine on industry updates. Keisha?
Hi, everyone. Thank you so much, Michelle. I appreciate it. And look, I am so happy to be here today. Thank you all for joining us and all the amazing presenters that we had so far. I think it was amazing. Each session, we're walking away with a wealth of knowledge. And as Michelle mentioned, my topic is breaking silos, leading the data revolution in healthcare. And you already got my long bio, so I won't give it again. So let's talk about silos. What are silos? I thought this was a great image of silos, especially in healthcare. And in simple terms, silos in healthcare, it occurs when data, departments, clinical teams, operations, they're in isolation and they're not talking to each other. And as we just heard in Dr. Angelica's presentation, at the heart of everything that we do, whether it's data, AI, telehealth, remote patient monitoring, is our patients. And on my, as a day-to-day role in compliance with organization, it's heavy on documentation and training physicians and coders to make sure we document compliantly and that the patients are at the center of everything. But I will say, throughout everything, all the presentations I listened to, I can tell you firsthand that silos are extremely, it happens every day in healthcare, and we're looking to break that silo. So Also, think of them as information islands. As you can see here on the screen, we have all the different information just hanging out in different islands, different pieces, different teams. Sometimes there's no I in team. So we're looking to bridge that gap and bring it together so that we can help our patients. Women's silos in digital health, of course, is one of the significant ones that occur when women's expertise, our leadership, so I'm going to include myself in there because I would say the climb to leadership, especially in healthcare, wasn't always easy, as I'm sure with many of you who are attending and have been speaking today already. And our perspectives are isolated, sometimes underrepresented in the development and governance and implementation when it comes to healthcare and technology and data in organizations, big or small. So, of course, as the market continues to expand and foster better health, better outcomes, value-based models, we're looking to shift. We're holding a lot of ideas. We're hoping that our information is not fragmented and they take the information that we're providing and really implement them for the organizations. So why does this matter? And healthcare data and breaking silos. So as we heard throughout the day, women are a majority of the healthcare workforce. And the data, I was smiling because I was like, okay, we all got solid information when it comes to data, but we are underrepresented in leadership and data roles, especially in tech, AI, telemedicine innovations. Healthcare generates an enormous volume of data, especially since we moved from paper. That still stresses me out when I do audits. But we moved from paper, now we're on electronic healthcare records, which is amazing, right? But we need to integrate the telehealth and the different platforms into one. They are very still separate. So it's really hard to kind of get the provider's full clinical picture on their patients. So despite growth and different tools that we have, gender data gaps still exist significantly, particularly in women's health areas, digital care like telemedicine, and various chronic conditions, heart failure, diabetes, you name it. It continues to be an issue with gathering real clinical data on our patients so we can foster this. So interoperability, moving beyond just collecting data, that's what we're looking to do, to making sure systems are actually talking to each other like we are doing now, right? We want to make sure our systems do that. As we mentioned before, women make up 70% of the healthcare workers. That is a significant amount. Even in leadership and even in compliance, even in coding, we have a higher amount of coding or even women, but in leadership roles, we don't see that. But only 25% in leadership positions, including digital health, as I mentioned before. So without women in leadership, telemedicine or telehealth strategies and digital tools may not fully reflect the needs of women and the diverse populations. In one of the courses that I teach, patient care navigation course, we teach how these patient care navigators can be that bridge between healthcare and the clinical team, and also help the patients in figuring out the different telehealth and the different platforms that we have now too. So we're looking to increase leadership to reduce that gap and that 25% and see more women, train more women, mentor more women to become leaders in these roles and see that number and see the disparities when it comes to our patients and even leadership decrease as well. When we talk about interoperability and data sharing, we have electronic health records, as I mentioned, billing systems. We have significant ones. We have in-house, we have third-party billing systems, population health and platforms that we use, as well as the different various telehealth platforms that was mentioned. And the problem, historical medical data often underrepresents women and minorities. In a lot of the prior history and in data collection, a lot of studies were really done on men and not really women, especially minority women. And so right now you see a lot of data collection and AI and different reports, and they're trying to shift and move that and, close the gap. So women in data leadership are auditing algorithms in AI, and we don't want to see the bake-in or the bias, but we want to make sure that the information is really accurate and concise. So we want to see that 80% decision maker in families, they are women. We want to see them in the field, that they're also paying attention to what is going on with our patients when it comes to chronic conditions, acute problems, really looking at that data using AI and other tools to really make sure it's accurate and concise so that we can treat our patients who are at the center. And what happened with silos is that we have separate workflows, not only in healthcare, right? You have one team not talking to each other, but there's a lack of communication. Same thing when it comes to the different systems. Yes, we have so many tools. We have a lot of telehealth platforms, remote patient monitoring platforms, billing platforms, you name it, but no, they're not really talking to each other, right? So we need to get that information, the data from our patients, and we also need to implement it, and so we can lessen, as I said, that wide gap that we have. So we want to see a shift from retrospective to prospective, moving from looking at what happened to predicting what will happen because of the data that we have created, and from the leadership positions that we're creating, right? So using the data to identify the risks within our patients. So there's different digital transformation. Women are at the forefront of integrating digital tech into healthcare, and we had quite a few women from the beginning all the way to now who have been really instrumental in that process. So we have AI, diagnostic and predictive analytics, including remote patient monitoring. And with the AI, everyone gets nervous, like, are they replacing humans? No, they're here to help with more efficiency. Of course, AI is the information that we feed it, right? So remember, there's humans that's feeding the information. So we want to make sure that it's correct information that we're feeding it, but so that we can really utilize it and it can be a really strong tool when it comes to data collection and leadership. Telemedicine and mobile health solutions, expanding access, improving care delivery, and personalizing treatment plans when it comes to our patients. We also have the different interdisciplinary collaborations. So we have clinicians, engineers, policymakers, all coming together to solve complex health challenges. Impactful women data. So Michele doesn't know that she's on here. I didn't tell her, but I thought, who else can we include when it comes to women that's shaping the health? So her idea and her vision brought forth this amazing event today with collaboration. You see what I did there? There was collaboration with teams and women spanning different continents, and everyone's picking a different topic. But as you can see, a lot of our information is circling back. And she has, as she mentioned before, internal medicine provider. She has utilized telehealth in her practice for a long time. And she also, besides being president, right, of the ISfTeH, she continues to lead women and advocating for women and healthcare and her patients. So I thought, who else, right, to have as number one? And then we also have Judy Faulkner. She's the founder and CEO of Epic Systems. And for those in the United States, we know that a lot of hospital systems as well as smaller clinics utilize Epic. I will say it's truly amazing. I was on an Epic committee helping them tailor it to the different systems, but it's super impactful no matter what state that the patient may go in. If that provider is on Epic, their information will be in there. And I think that's super important as well. We also have Dr. Rashima, and she is the CEO of Vertex Pharmaceuticals, blending biotech and AI. And then we have Teresa Graham, which is also the CEO of Roche in the United States, advancing personalized medicine with telemedicine and data integration. So what does coming together and breaking silos look like? Exactly this image that's on the screen. We want to see it coming together. There is no I in team, but when we're talking about bridging the gap, especially when it comes to leadership and data, this is what it looks like. We're coming together, the different teams collaborating, data interoperability, inclusive leadership, and data in digital health. Collaboration, one of my middle names. I always say, depending on the day of the week you talk to me, it might be compliance, it might be research. Today it's collaboration, because in order to break down silos, we need collaboration. So collaboration across domains, we talked about it a few sessions ago, across the globe. So integrating clinical expertise, data science, and telemedicine technology. Cross-disciplinary teams produce richer insight patient care virtually and in person. Ensure, when we talk about gender-inclusive digital health practices, ensure telemedicine platforms captures women's health, nuances, and diverse population. This is something I speak about when I teach the patient care navigation. And also I use my mom as an example. A little while ago, I think in the beginning session when Cherisse had spoke, and it was a third opinion, as I mentioned, that found her cancer. And by the time they found it, it was already stage 4. Mind you, this is a nurse who knows signs and symptoms very well and was able to continue to push. But this is when we're talking about data, right? And the different cultures. So we want to utilize it in a way that be able to help our patients. Use analytics to identify disparities and inform policies, because there is a lot of disparities, no matter even if you're living in the United States or internationally. Research matters, right? We always need to take a look at the community that we're serving. And I always encourage leadership to go out and talk to the community. And that's always the best way in surveys that we learn. Purposeful mentorship from women in data. You find a mentor that's a leader, you want to grab onto them, right? So I'm grabbing onto a few of them on this calls. They're going to be finding me in their messages. And you want to learn from them when it comes to AI, when it comes to telemedicine and leadership roles. What are they and how can we get into them? What do I need to do? Support network like Women in Data, Women in Telehealth to expand career pipelines. I know Tori mentioned about entrepreneurship. That was a new role, right? Finding someone that I can shadow, and that was able to mentor me in that area, with now moving from leadership in a hospital to running a business, and including everything that I do in there as well too. So this is another slide where I'm talking about when we implement data, what does it look like when it comes to our patients and leadership, right? So we have patient care, medical research, risk assessments. So it's the siloed way versus the data revolution way. So the silo way is treating a symptom in the emergency room. Using wearable data to prevent ER visits entirely will be the data revolution, right? The remote patient monitoring, the diabetic monitoring, that one that can monitor their pressure, whether it's high or low, it depends. That's important because that will be able to keep our patients out of the hospitals. Medical research, excluding women from trials due to hormonal complexity. And we've heard data earlier on in the day. We need to get more women information in there, right? Using them when it comes to trials, using big data to study sex-specific responses to medication, and not just checking boxes, but using data to really drive equity and ensure funding reaches the patients that it needs to care the most. So we want to impact. It impacts on care, so you can see the circle of life like I see. And informed decisions, right? We're using leadership to make informed decisions for our patients. We find better outcomes, financial integrity, as well as complete clinical picture is captured of our patients when we're using data, and correct and accurate data at that, I should say. And as you can see, my silo is carved out like a vegan pizza. But breaking the silos, We want to break the manual workflow. We want to integrate AI when we can, break the cultural resistance. So we know that oftentimes everyone's resistance to change, right? We know we had a lot of male leadership. There was resistance. Now we have female leadership. And same thing when it comes to data. We want to break down that norm of integrating technology and really just educate our patients, providers, organizations on how it can be used safely and compliantly to help them. And this helps break the trust barriers. And we need more connected data, right? Not disconnected or silos, but connected. So we want to make sure we engage and empower. I love that. Advocate for gender balance. Promote educational pathways is huge for women in digital health, data science, and telemedicine. We want to become champions when it comes to ethical use of health data and telemedicine. We want to prioritize transparent. That's another thing. Transparency is huge when it comes to patient-centered digital care. Ensure equity in telemedicine access, particularly in underserved populations. You see, I had to highlight that there. Mentorship and visibility, I just spoke about that. So we want to continue to highlight women's achievement as we've been doing all day when it comes to this amazing conference in telemedicine and the digital health space. This is where we get to find out what is everyone doing in different spaces in different countries, and how can we become a part of that? How can I help you? And that's one of the things I love, especially with our working group. Who's working on what and how can we be of assistance? So build mentorship programs to inspire future leaders, because we know the leaders are in tech. We want to continue to break down the silos. So create structure that encourage regular communication and collaboration among women in digital health space. We've been doing that. We've been exchanging emails and different LinkedIn, and we can continue to do that. And everyone seems super open to collaborating, which is amazing. We want to align our goals. If you notice, even when the other presenters were talking, we all have like the shared common goal. So we want to continue to develop shared metrics that focus both clinical accuracy, financial integrity, and also foster shared learning. The different platforms so that we can continue to teach future women leaders on how we can collaborate and integrate and implement ongoing education and build mutual understanding and respect for each other. So some new roles we want to continue, right? AI is not going away. I always say before AI, we had CAC, we had the computer assistant coding, which was there and it continues to help. And so now AI is just like an updated version of that. We have the remote patient monitoring, we have telehealth, we have informatics, right? We need someone to collect data when it comes to organizations. Data analysis and really analyze that, and compliance analysts as well. So synergy, how do we come together? We want to solve problems together and work towards a common goal, as I mentioned. Collaboration models foster culture and shared responsibility and continuous improvement. So the work is never done. We want to continue to grow and get better. And how do we do that? We want to demand sex disaggregated data in every study, every platform, every policy. Invest in women-led health tech and champion female principal investigators. Use digital health tools to break access to barriers for women globally. And last but not least, alone we can do so little, but together we can do so much. I just love that quote. And as you can see on the right side, we're putting the puzzle together. So data revolution it's not going away. It is here to stay. I always say, like telehealth, it's not going anywhere. It's in bite size, right? We want to make sure it's visible. When women lead data revolution, we ensure that algorithms of the future are built into realities, our day-to-day reality, and not just convenience for a few. So we want to continue to mentor, sponsorship, leadership pipelines when it comes to women, and healthcare's future will be data-driven. So but it must be ethically led, right? So, and women belong in the center of transformation. I know we were talking about that before, and I so believe it. So we're putting that piece together. And that is all. I want to thank you all for being amazing. I hope you enjoyed the presentation, and I'm going to turn it back over to Michele and see if you had any questions in the chat. I'm going to look at the QA box. Thank you. And let me stop share.
Excellent presentation. Thank you. So inspiring. Yes, very inspiring. Are there any questions? I'm looking forward to all the collaboration that's going to come from this. So your point and your focus on silos was right on time in terms of where we are in the digital transformation of healthcare. Just thinking about a number of conferences and meetings I've been attending lately, and that seems to be this recurring theme, progressing, moving from silos to and fragmented, or sometimes I've heard pilotitis in the area of digital health, to finding ways to collaborate and integrate on a large scale. So thank you. I think it was right on time with the times, right on time with the times. Any other comments? And if not, we're going to move on to our next speaker. And the topic is digitally driven and human-centered, women shaping the future of access to care, by Dr. Danielle Magalhaes. Danielle is the co-founder and CEO of eHealth, a digital health company focused on human-centered healthcare transformation. Her work bridges strategy, leadership, and digital innovation to improve access, equity, and system performance. She's also gained international research exposure through a fellowship at Mass General Brigham in Boston. She is the co-founder and CEO of eHealth, a digital health company focused on human-centered healthcare transformation. Her work bridges strategy, leadership, and digital innovation to improve access, equity, and system performance. She has also gained international research exposure, and we are looking forward to hearing from Dr. Danielle. Dr. Danielle?
Can you see the presentation?
Yes, we can.
Such a responsibility to present something after so relevant, so important themes and presenters here. It's a high-level event. Thank you for the audience. Thank you for everyone. So just before we dive in, just a quick background of me. I'm Dani Magalhaes. You just talk about it. I'm CEO of eHealth. And I spend my days designing hybrid care models that improve access and equity across Brazil. So bringing insights from my journey, I have a core belief that is true healthcare innovation only happens when we connect technology with empathy. So digital health is transforming systems around the world. We know that it's so rapid. We see rapid adoption, new technologies, hybrid models emerging. But despite of this momentum, the biggest challenge, unfortunately, remains, which are equity, access, and human-centered design. Technology alone doesn't guarantee better care, unfortunately. Many populations still struggle with access. So literacy gaps persist, systems remain fragmented, and innovation often fails when it forgets the human experience, like Keisha just said about her mom. So it's the first thing that we should think about. So Human leaders bring a unique combination of empathy, systems thinking, and collaboration. These qualities help to bridge innovation with real world needs. In digital health, this combination is essential because technology must elevate human care and not replace it. But this is not an intuitive feeling. It's backed by data. There's a research from many research, obviously, but a research from Harvard Business Review that demonstrates that organizations with diverse leadership teams report 19% higher innovation revenues. So by leveraging collaborative leadership, humans are uniquely positioned to bridge the gap between technological innovation and real human needs, driving equitable solutions. Trying to pass. So many people are talking about pivoting careers, but innovation is not about moving forward for the sake of the movement, just it. Impact comes from purposeful alignment, knowing where digital tools can genuinely amplify care, improve access, and reduce the real inequities that we have around the world. Telemedicine, hybrid care models, patient empowerment, and data-informed pathways create opportunities to expand access and improve the outcomes, but they must be designed with human-first mindset. There is a recent clinical study published in British Medical Journal that hybrid care models delivers better outcomes, less mortality, and higher patient comfort for sure. Digital health adds the most value when it creates a bridge. Looking at this diagram, we can see in-person experience in one side and the digital scale in the other side. The magic happens in the intersection of them. By uniting them, we create a hybrid model that delivers absolute continuity of care and systemic efficiency. And at the end of the day, this is the only way to guarantee better outcomes while remaining entirely patient-centric. This is where digital health becomes sustainable and equitable. So here I propose a framework rooted in human-centric principles. Human first of all, accessible, scalable, evidence-informed, and equity-driven. I think that these pillars guide innovation toward impact. But to truly have impact, to truly transform healthcare, technology alone is not enough. We need the right leadership skills. We need the right leadership behaviors. This starts with empathy, ensuring our solution remains human-centric, as I have mentioned. And a strategic vision align innovation with actual needs. We also requires collaboration to unite the different stakeholders, data literacy to make informed decisions, and the adaptability to pivot in a rapid changing environment that we are immersed in. So when you look at the global patterns, we see that these leadership behaviors must adapt to unique regional challenges. For instance, Brazil is a huge country. Brazil has a huge population, and the primary focus is on expanding access to care. In the US, the priority is integration, interoperability, and they're pushing innovation forward. Whereas in Europe, we focus on building equity-driven models. For instance, Europe, the adoption of strict frameworks like GDPR ensures the patient's data privacy leads to design of the process. But meanwhile, Asia is leading strong digital literacy initiatives to empower their population. So that said, ultimately, no matter the region, we must remember innovation succeeds when it strengthens human connection, and leadership succeeds when it centers empathy for all. Just a moment. So the future of healthcare will be led for those who merge technological vision with empathy, by leaders who understand that digital innovation must always serve humanity. Digitally driven, human-centered, and shaped by humans who understand both. This is what innovation is. Thank you.
Thank you. Excellent presentation. Let me see if we have questions. I just love how all these presentations align, and as women, we are all on the same page when we are talking about digital health and what should be at the center.
It's interesting because techniques we can be trained for, but not behavior, not skills, not empathy. That's important.
Very important, and a very good point. Okay, so our next topic, connected hearts, digital health strategies for women's cardiovascular prevention. Perfect topic, timely topic here. So Dr. Simone Farah will be presenting. Professor Simone is a cardiologist and a pioneer in telemedicine and digital health, having been the first physician to earn a master's degree in telemedicine and telehealth in Brazil. She is the founder and chief medical officer of Fletic Digital Health, a company dedicated to driving digital transformation in healthcare. Dr. Simone Farah is a board member of the International Society for Telemedicine and eHealth and actively contributes to global initiatives advancing innovation, education, and women's leadership in digital health. Simone?
Hi, everyone. Good morning, good evening, and good afternoon, and even good evening to everyone. It's truly pleasure to be here with you all today. And firstly, I'd like to thank Michele. My gratitude for being here in so special event, and to thank ISfTH also for being here. So thank you, and thank you the audience for being here with us today. Just a minute, please. Now I can see it. Okay. Can you hear me okay? Yes?
Yes, we hear and see you clearly.
Okay, thank you. Well, as a cardiologist and telemedicine eHealth specialist, I'm really honored to speak about a topic that is both urgent and transformative, that is connected hearts, digital health strategies for women's cardiovascular prevention. And today, I'd like to explore how digital health initiatives, when, of course, evidence-based and ethically implemented, can reshape prevention, improve access, and empower women to take control of their cardiovascular health. I will present some of the digital strategies that impact on prevention of cardiovascular disease. So that is something that every day I face. So here in Brazil.
Yes,
And
Sahman, I'm sorry, I don't mean to interrupt, but your presentation, your
sorry.
slides are not maximized. It needs to be
Oh,
in,
sorry.
yeah, no
Okay.
worries, in presentation mode. Yeah,
Oh, it's okay now?
there you go. Yep. Thank you.
Okay. Thank you. So, cardiovascular disease remains the leading cause of death among women worldwide. So, um, women typically has atypical symptoms. So, usually it's underdiagnosed, undertreated, and underpresented in the represented into cardiovascular research. So, as you see, we need strategies to change this reality. So, digital health strategies allow us to care, to scale, and to present interventions and to identify the risks of cardiovascular disease. So, as we increase early detections of cardiovascular risk factors, we can faster the diagnosis and do the the right treatment. So it's really urgent. And as presented before, digital health encompasses telemedicine, eHealth, mobile apps, wearables, remote monitoring, and of course, AI. So today I will present some strategies to that we can implement to prevent cardiovascular disease. So when we talk about telemedicine and health, we can implement remote consultations, as you know, that we improve access and, of course, clinical outcomes for the patients. Telemonitoring is even important to, especially for patients with chronic disease, for early detections and rapid response. Teleeducation in health in different settings, especially at universities, is really, really important to prepare future leaders in telemedicine, in telehealth, and for them to know how to deal with that, and to improve engagements and reduce, of course, missed appointments. So we know that all of this must impact on improving cost effectiveness for health systems, not only here in Brazil, but of course around the world. Second, wearables devices. That's something that I prescribe a lot for my patients, and that's something very useful for continuing tracking of heart rate, activity, and sleep, early alert triggers for clinical interventions, improve lifestyle adherence, and early detection of arrhythmias, especially atrial fibrillation, that we know that's really prevalent in the population, elderly population, and we can avoid stroke when we detect atrial fibrillation by using these wearables. And third, mobile health apps by monitoring our habits, goal setting reminders, personalized feedback loops, and supporting weight loss and blood pressure control. So as we use this mHealth, we can do the early diagnosis of high blood hypertension and obesity and other disease that we can implement early strategies. And of course, AI to predict risks, trajectories, suggest personalized intervention. And as we see, machine learning predicting cardiovascular risk beyond traditional scoring systems, there is something that we also can use daily in our practice too. So as you can see, we have a lot of strategies to implement on cardiovascular preventions. But of course, when we talk about digital health, we may consider that to implement, we may face main barriers, as said before, here, as digital literacy, data privacy concern, connectivity, and integration with systems like interoperability. But we also have already solution that we may implement by training all the, not only the patients, but all the professionals in digital health, privacy and safeguards, and as I said, interoperable platforms also. So when we have all this together, we can improve strategies to face the cardiovascular disease. So digital health is not only an add-on, it enhances outcomes when integrated, of course, into clinical workflows. And we need to take all these strategies and think how we can scale that. So if we implement those strategies, we can target reach to underserved women, include socioeconomic and geographic equity, I said here before, empower women with data and self-care tools. That's really important for early detection, integrate tools into preventive care plans, advocate for digital literacy programs, and measure outcomes and refine that. So as we move forward in digital health strategies, we must remember that technology alone does not transform care. We need connection, we need empathy, and we need, of course, evidence-based actions too. So when we have some initiatives as this event, we of course can put all this knowledge and experience together to prevent cardiovascular disease, and we know that's really, really urgent worldwide. So I'd like to thank again Michele and ISfTeH for this initiative, for being here with you all today, and will be a pleasure if you have some questions. And thank you again. Thank you so much.
Thank you. Excellent presentation. Appreciate
Thank
it.
you.
Yes, yes, yes. Very informative. As a cardiologist, utilizing remote devices, I'm curious in terms of funding. How are patients able to afford the remote monitoring devices? I think it's a wonderful tool to have. I've had some barriers in my own practice in terms of affordability. I mean, Let me let
Yeah,
you answer. Yeah. Yeah.
that's a good question because we face that in Brazil also, Michelle. Only my private practice, I can, deal with this device, prescribe these wearables, and we see that it does make a difference because I would say that every 2 weeks, I diagnose atrial fibrillation in a patient in my private practice, but it's not a reality in the public health in Brazil. But if we implement telemedicine in health by, teaching the patient how to monitor the other primary professions, how to think about that. So I think it's the first step because on teleconsultation, I practice telemedicine every week with the primary care as a cardiologist. So we discuss all the patients, and what I can see is when we discuss, of course, they learn about this clinical discussion. So it comes like a training, a digital health training. And doing that, we can detect early risk factors and implement early strategies, to prevent stroke and myocardial infarction and also atrial fibrillation. So, but it's a challenge here also.
Yes. Yes.
For your question.
Great presentation, very informative, amazing, Simone, of course, amazing,
you.
amazing. Okay. Okay. Our next presentation, Human-Centered Digital Health Powered by Women, Designed for All, has been shared by Professor Dr. Nelly Abalatha. And as I mentioned, she, at the last minute, was unable to be here live due to the situation, the current world events. And I will be sharing her presentation in her absence. She is a board member and chair of publications at the International Society for Telemedicine and eHealth, and founder of CVWD Women's Net, a platform advancing women's leadership in healthcare and academia. She is also a physician executive, clinical professor at Cairo University's Qasr Al Raini Medical School, and a global advisor in human-centered healthcare and higher education. She serves on the many international advisory boards, physician committees, and working groups. With over 25 years of leadership across clinical practice, academia, and health systems transformation, she is recognized for advancing digital health, ethical AI, accreditation, and medical education reform. Her expertise spans Egypt, the MENA region, and global platforms across Europe, the US, and Asia. Her mission is to bridge academia, healthcare, and technology to build human-centered, innovative, and future-ready health systems. So I am going to play her presentation and her audio. If you have any issues, just send me a message. Oops. Oh, let me go back to my screen. There we are. All right. All right, here we go. All right, let me play a presentation. Good morning, good afternoon, and good evening to everyone joining us from around. Good morning, good afternoon, and good evening to everyone joining us from around the world. I'm Professor Nelly Abalatha, and it's truly a pleasure to be part of this global gathering, celebrating women who are shaping the future of digital health.
When the COVID-19 pandemic disrupted healthcare systems globally, something extraordinary happened. Healthcare systems that had debated digital transformation for years suddenly changed almost overnight. Clinics moved online, telemedicine became a lifeline, and digital platforms connected patients and physicians across lockdowns and borders. Women made up to nearly 70% of the global health workforce, carrying much of the frontline response while simultaneously adapting to these new digital systems. And the scale of that transformation was remarkable. In many countries, the use of telemedicine jumped from about 16% of physicians before the pandemic to more than 80% during the pandemic. What we thought might take a decade happened in a matter of months. COVID did not just challenge healthcare, it accelerated the digital future of healthcare. But the real question today is not how fast we digitized healthcare. The real question is whether we designed that transformation around people. And that is why we must talk about human-centered digital health, powered by women and designed for all. Let me briefly share the path for today's conversation. We will explore why human-centered digital health matters, the critical role of women already playing in healthcare systems, the risks of gender bias in digital technologies, how inclusive design can advance equity and trust, and why women must help lead the future of digital health. We are now living in a world where digital tools are advancing faster than our ability to implement them safely and meaningfully. And so human-centered digital health asks a different question. It's not what technology can do, but what people truly need. It means redesigning care around what matters most to patients, to families, and to the healthcare workforce. Human-centered solutions must be intuitive, accessible, culturally intelligent, and trusted. Most importantly, they must ensure that no woman, regardless of geography, age, literacy, or income, is left behind in the digital era. Women represent nearly 70% of the global healthcare workforce, yet they remain underrepresented in leadership roles in digital health. Women are the ones delivering everyday care. They are the physicians, the nurses, the caregivers, the educators, the coordinators, and often the innovators closest to the patient's need. They understand where systems break. They can see where patients struggle. And they experience firsthand where digital tools empower care or overwhelm it. Human-centered digital health begins with listening to women. Many digital health tools today are built using male-dominant datasets. This creates blind spots that affect diagnosis, usability, and outcome for women. The consequences of this is real. Algorithms that misdiagnose women, chatbots misinterpret systems, and health apps that ignore social and cultural realities, and medical devices that are calibrated primarily on male physiology. When women are absent from design, digital health becomes another barrier instead of a bridge. So inclusive data and diverse design teams are essential for safe and equitable innovation. So how can we design digital health with women in mind? Human-centered design requires more than technology. It requires listening to the real users. This means building systems with gender-balanced development teams, diverse clinical voices, with patient participation in the design and continuous testing with real users. When women are involved in the co-design as clinicians, as caregivers, as patients, digital tools become more usable, more relevant, and more ethical. Human-centered design improves healthcare for everyone, but especially for those most often left behind. To truly serve women globally, digital health must be mobile first, which means recognizing how many women access the internet. It must be language accessible, especially in multilingual regions. It should protect privacy because safety and confidentiality matter deeply. And it must be culturally adaptable, not simply copied from one region to another. When digital innovation respects cultural realities, it builds something essential in healthcare. It builds trust. As healthcare increasingly embraces AI, the key question is no longer can we build it, but rather should we build it and how? Women bring critical strengths to shaping ethical AI through empathy, collaboration, system thinking, and awareness of human vulnerability. From AI governance to telemedicine design to data privacy framework, women are essential to ensuring technology enhances, not only replaces, the human connection. If women are not at the table, AI risks reproducing inequities it claims to solve. So how can we build networks to ensure that doesn't happen? Well, talent does not rise alone. It grows through mentorship, through sponsorship, and through strong networks. To build the next generation of women leaders in digital health, we need pathways from clinical practice to digital leadership, from technical skills combined with clinical expertise. We need leadership confidence and executive presence when we need collaboration across sectors. Leadership is not an individual journey. It's a movement by all of us. Women thrive when they share knowledge, challenge each other, and co-create solutions. So what does the future of health care look like? What does the future of human-centered digital health look like? It is a future where equity is built into every algorithm, where privacy is treated as a fundamental right, where digital literacy becomes universal, and interoperability strengthens continuity of care. And of course, where technology amplifies compassion rather than replacing it. It is a future where digital health is shaped by women. Because when women lead, healthcare systems become more ethical, more inclusive, and more aligned with the real human needs. Before I close, let us remember, women are not only users of digital health. They are the visionaries, they are the builders, and they are the guardians of a more human, more just, and more connected healthcare future. When digital health is human-centered and woman-powered, it becomes designed for all. Our commitment here today to advancing human-centered digital health is profoundly appreciated. By championing women leadership and ensuring inclusive design, we can collectively shape a future where technology truly elevates global health outcomes for everyone. And let's continue this vital conversation and further collaborate together to build more compassionate, more ethical, and effective digital health ecosystems. Thank you very much.
So that's a first for me, sharing someone's presentation. And if you have questions for Professor Nelly, we can certainly forward those questions later. Her presentation was excellent, and we appreciate her actually creating a plan B just in case. And it turns out, yeah, we needed her plan B. So I appreciate Nellie's contribution. And again, if you have any questions for her, you can put it in the chat and we will share it later. And as you can see, she shared her details on LinkedIn if you'd like to reach out as well. To welcome Dr. Trina Stout. The topic for this session is healthcare disparities, closing the gap using digital health tools. Dr. Trina Stout is a Barbadian-born, board-certified medical oncologist and hematologist, and the founder of Carrywell Health, a hybrid oncology practice delivering timely, evidence-based cancer care across the Caribbean. She earned her medical degree from the University of West Indies, completed her residency at SUNY Downstate in Brooklyn, New York, and her hematology-oncology fellowship at the University of Connecticut. Dr. Stout has practiced in both the United States and Barbados and is a member of the American Society of Clinical Oncology. Her work centers on reducing delays in cancer treatment and expanding access to high-quality care for patients throughout the Caribbean. At Carrywell Health, patients receive timely, compassionate care that restores hope and gives every person the chance to fight and live. Dr. Trina Stout.
Good afternoon, everyone. Thank you to the International Society for Telemedicine and eHealth for the invitation and for choosing International Women's Day as a backdrop for this conversation. As Dr. Griffith said, I'm a hemo physician and I split my practice between the United States and Barbados. And the question I'm here to answer today is one I've been asking since I moved to the US in 2013. How do we close the gap in healthcare outcomes between the Caribbean and countries with the infrastructure to do better? And increasingly, how do digital tools help us to do that without waiting another generation? So I want to begin where this actually starts with a statistic but rather a series of moments. I've watched many people, including family members, navigate the Barbadian healthcare system for various diagnoses, but those more dear to me being cancer diagnoses. And what I observed as a young woman, long before I was a physician, was that the care that was available for some people, and then there was care that wasn't. In 2010, while I was working in oncology in the public sector in Barbados, I saw the waiting, the traveling across the island, and sometimes traveling from other islands for some patients just to access a specialist. I saw treatment interrupted because of drug availability or lack thereof and costs, and I saw families absorbing what the systems could not. And then I moved to the United States in 2013, and I entered a completely different world. Same diseases, same biology, radically different infrastructure, resulting in radically different outcomes. What I experienced personally, the data confirms. On the left is the reality I trained in the Caribbean. Month-long waits to see a specialist, records fragmented, patients carrying their own records from doctor to doctor, no local access to clinical trials, minimal multidisciplinary tumor board coordination. And as we all know for oncology, this is pivotal to improve patient outcomes, and prohibitive drug costs. Patients in the public sector navigating a system alone, there's no coordinated infrastructure, and families working as best as they could to try to facilitate this coordination for their loved ones. Whereas on the right, in the United States, the reality in which I practice today, patients can see specialists within days. There's integrated electronic health records that follows a patient wherever they go with easy access. There's clinical trials available, even if not locally in their particular town, in a nearby city. Multidisciplinary tumor boards are the norm. There's financial support and assistance programs for patients when they can't afford care. And there's just overall well-coordinated care from diagnosis through treatment, through survivorship. So we see people with the same disease, but in a different system, which leads to a different probability of outcome. So before we go further, I want to anchor us in a shared definition, because healthcare disparities is a phrase that can feel kind of abstract, a bit clinical until you measure it. So we're talking about 6 concrete things here: time to diagnosis, time to treatment, stage at presentation, financial burden, geographic access, and continuity of care. These are distinct decision points. Every single one of them is a place where the system can either hold the patient or lets them go. When a Caribbean patient waits longer for a diagnosis, they inevitably arrive at a later stage, at this point usually not curative. When they can't afford treatment, they stop mid-course, and in many cases, they don't begin at all because the costs are so prohibitive. When the system doesn't track them, they fall out. These are predictable consequences of structural gaps, which means that they are preventable. These differences not only translate between the difference between early stage versus late stage disease, but ultimately life versus death for many patients. And this isn't a small problem. There's a projected 10 million healthcare worker shortage expected by 2030. The physician density in the Caribbean is 2.1 physicians per 1,000 patients, whereas in high-income nations, this is 3.5 per 1,000. And 80% of deaths in the Americas is driven by non-communicable diseases, the same cancers, the same cardiometabolic conditions, but with vastly unequal infrastructure to address them. And half the population still lacks access to essential health services, with a 2.2 billion people still remaining offline, which matters enormously as we're here discussing digital solutions. Infrastructure determines access, and access determines survival. That is not a hyperbole. That is the arithmetic of the public health situation that we face. Now, let me bring this closer to home. Home for me being the Caribbean. Because the Caribbean has specific structural conditions that compound these challenges in ways that require specific solutions. There's a specialist scarcity. In some islands, if there is an oncologist, there's only one to serve the entire population. And there are islands without an oncologist at all. Cross-island travel is not a metaphor. People are literally getting on boats or planes to receive care that they cannot access at home. And this, of course, comes with an associated cost. Drug access is an issue, with pricing being prohibitive and many newer drugs not being available in some Caribbean markets. Then we have fragmented systems. Public and private care communication isn't well coordinated. And the result is that patients fall between the cracks. Even within the same public institution at times, there could be one department that does not know what's going on with the care in another department, because something as simple as a paper falling out of the paper chart goes missing, and that leaves a gap in the patient's care. Limited interoperability. So the data does not follow patients. It's not interconnected. The only common link is the patient telling their same story over and over again to different physicians. And many times they don't even have some of the investigations or tests available to carry to another physician. For example, I see patients for second opinions at times, and they don't want to ask their current provider for their records because in some cases they don't want them to know they're getting a second opinion and they don't have the records. And that results in our offices having to call multiple healthcare institutions to request each individual test this patient has done. Again, this is a time factor. It delays the time that you can see the patient and provide comprehensive recommendations. I heard supply chain gaps. This is an issue where you can't even get basic continuity of treatment at some times, because what's available today may not be available next week, may not be available next month. And many times most suppliers can't tell you when it's going to be available, because they also too, in many cases, have not digitized in ways that would alleviate this problem. And these things do not occur in isolation. They compound each other. And they compound on women the most. On International Women's Day, I want to name something that the aggregate data often smooths over: the gendered cost of healthcare disparities. Women in the Caribbean experience the system in 3 distinct registers: as caregivers, as patients, and as healthcare workers. Women are holding families together while systems fail them. They're caring for parents, a sibling, a child, a spouse, sometimes all of them at once, while their own health waits. And as patients, seeking care costs money that women sometimes often don't have. They lose wages, they have to travel across islands sometimes, time away from work and family. And sometimes the price of getting diagnosed can be the reason that many women don't. As healthcare workers, women are the backbone of Caribbean healthcare. The doctors, the nurses, community healthcare workers, informal carers. The system runs on their labor, many times unrecognized. When we close the gap for women, we close it for everyone that they also carry. So what are these tools I'm actually talking about? Before I show you how they close each gap, let me name them. We have telemedicine, electronic health records, clinical decision support, remote patient monitoring, mobile health, and AI-assisted triage. These are not futuristic. They exist. The question is whether they're designed for the environments where they're needed the most. So where does digital health come in? Let me take you through the 3 gaps, and for each one, we'll talk about the specified digital response. So gap 1, the access to expertise. As we mentioned before, many islands do not have the specialists that are needed. And the specialists are a fraction of what exists in high-income systems. This results in patients waiting months, traveling long distances, and presenting, later in the disease than we would like. So the digital response to this, telemedicine, you get specialist access without travel. Specialists, this allows for cross-border consultation. There's virtual triage so patients can get the right care at the right time. And you essentially redistribute the expertise across the islands that cannot each sustain their own specialist workforce. So the expertise travels so patients don't have to. Gap 2, fragmentation and continuity. So telemedicine fixes the problem of getting the patients in the system, but getting into the system is not the same as staying in it. And the Caribbean patient experience is often one of re-entry, the same intake over and over and over again, because records do not follow the patient. Referrals sent into the void, they're never tracked. It's not clear if the loop is ever closed. Did the patient see the provider they were referred to? And if they weren't, how do you get back in touch with the patient to ensure that this is done? Public providers can't see what private providers have done. And sometimes other public providers also are not seeing that. So the digital response here is the workflow. Structured digital intake. So every patient enters the system the same way and nothing falls through. Closed loop referrals. A referral is sent and is tracked and is followed up on. Shared care plans. So public and private providers can see the same patient history. Taking also a burden off the patient who, as we could imagine, becomes frustrated having to regurgitate the same information over and over. Additional secure messaging allows communication without phone tag or a lost fax, or realistically, a lost piece of paper with your referral letter on it. Remote monitoring, especially post-treatments, allows patients to stay connected between visits and allows for greater continuity of care. What we're building is a system that holds people inside of it, from diagnosis through to recovery through to survivorship. The third gap is probably the most invisible, data blindness. Right now in the Caribbean health systems, we cannot reliably answer these questions. How long does it take from first symptom to diagnosis? What stage do most patients present at their first oncology contact? What's the rate of loss to follow up? And what's the wait times by district, parish, or island? We cannot fix what we cannot see, and we cannot advocate for what we cannot prove. Digitization creates visibility, which then enables strategy, and strategy drives policy. And policy ultimately changes outcomes, which is what we're all here today to try to drive forward. So the framework. What I've described is not just a collection of apps, it's a system with 3 layers: the access layer, coordination layer, and intelligence layer. So within the access layer, we look at telemedicine and remote patient monitoring. This is how people reach the system when the system isn't physically near them. So the entry point. The second layer is the coordination layer. Electronic health records and clinical decision support, the layer that keeps the patients inside the system from the first contact through their entire care plan. And then the intelligence layer, mobile health and AI-assisted triage. This allows for population visibility. This is the layer that converts the data into strategy and strategy into policy change. Digital health is infrastructure, not an add-on, not a pilot. Infrastructure in the same way that roads, power grids, water supply are infrastructure. This is how we must view digital health. And this is the framing shift I'm asking us to make today. I want to show you what this looks like in practice. So in 2013, as I mentioned, when I moved to the US, I asked the question, how do I bring what I have access to back home? Not eventually, but now. The answer came a few years later during the COVID-19 pandemic. And that answer was Carewell Health. It is a hybrid practice which uses digital health platforms designed specifically for the Caribbean context. So for small island systems, for cross-border care realities, and for specialist scarcity. And for the hybrid environments that Caribbean patients actually navigate. At its core, there is structured triage, so intake is consistent. We utilize closed-loop referrals, so nothing is lost in transit. And longitudinal tracking, so patients are followed across their journeys. Cross-border expertise is embedded into the workflow, as I am a physician currently sitting in the US, and I am the lead physician providing care to patients in Barbados at this time. Their patients are allowed to have access to guideline-based treatments without having to travel outside of the country. Wait times have been decreased significantly, and outcome monitoring so we can build the evidence as we go. Carewell has created a bridge, and it's built from experience and anchored in the Caribbean. Now, before I close, I need to name a few things if I'm going to be honest. Digital tools can also widen the gap. If we design for the world we wish existed rather than the world that actually exists, then we're building solutions that serve the already advantaged. And I want to be honest about this, including about Carewell. Reliable connectivity is an assumption, and patients don't always have it. They also don't always have the digital literacy. So where broadband works, we use it. Where it doesn't, we fall back to WhatsApp calls or videos. Where connection is intermittent, we use asynchronous messaging. So the patients can send us a message and then the physician can respond when they can. So we're not outside the constraints that we've listed, but we're trying to work within them while advocating for the infrastructure investment that eventually removes these constraints and makes this platform available to all. With digital literacy, it's an assumption that most people have this or at the high level required for some of these applications and tools. So we require patience with onboarding, building trust, especially in an aging population that we see not just in the Caribbean, but worldwide. And it needs to be built in as part of the design and not an afterthought. Also, strong purchasing power. These devices that patients need to have in order to use this digital care, they cost money, and access to a telemedicine platform isn't free. We don't have the national interoperability that we would like. Most Caribbean systems don't yet talk to each other. And Carewell is trying to bridge this by design, but it is a real gap. So let me bring this to a close. Healthcare disparities are structural, and structural problems require structural solutions. Digital health is infrastructure. The path moves forward in 3 moves. You design for constraint, build for the resource-limited environment, and you build something that works everywhere. Build resilience, systems that hold patients even when the grid goes down, the drug supply is interrupted, the specialist is off island. And then you scale this globally. When digital systems work in the most constrained environments, they can work anywhere. Barbados taught me everything I know about what it means to care for people when the system is imperfect. That is where my medicine began. That is where Carewell began. And on International Women's Day, I want to close by saying this. The women in the Caribbean healthcare, the doctors, the nurses, the community health workers, the mothers who delay their own diagnoses, and the daughters carrying their parents to a system not built for them, they deserve this infrastructure. Thank you.
Thank you, Trina. Excellent presentation. Do we have any feedback, questions, comments? I had a question regarding the level of government support. Is Barbados digital friendly government? Do you find a lot of support? Because it seems in these types of environments, government buy-in as a
Is
stakeholder
needed.
is critical to the expansion that you're
Yeah.
looking for. Mhm.
Yes. So currently there is an arm of government looking at innovation and tech, and there's a sub-arm of that called Future Barbados, and they're really driving to advance digital solutions. And there's a sub-arm for help looking at healthcare, creating incubators for entrepreneurs to help develop that aspect of care. But I would say that we need more buy-in from the ends of integrating the various players, so the labs, radiology, facilities, because so we use an EMR within our practice, but to have it integrated, so we really optimize its use requires talking to each facility to try to get that done, as opposed to there being a blanket policy by government that allows for that. And because it's not clear, many of them are hesitant. The same for pushing prescriptions directly to pharmacy. That requires policy change at the governmental level. That's been in play for a while, but hasn't, come to fruition. So even though we have the broad tools that to try to digitize our practice, we still meet various limitations and integrating it in a way that is, say, in the US or in Europe and in these first world countries. So there definitely needs to be more government buy-in and more public-private sector partnership. Our main hospital is still primarily paper-based. So if when we have to send patients there, we don't really get back a note to know what's happening or to follow up on that care other than what the patient tells us. So these are real limitations, and I'm excited to see where the Ministry for Innovation and Future Barbados goes in terms of trying to advance this, and working with them hopefully to try to give some insight as to what would work best in a healthcare facility with my experience here in the US.
Thank you. Let me
Well,
see. I think there's great data, really great presentation. In terms of the rates of, I think you were mentioning that you don't even have the data when it comes to time of diagnosis, late stage diagnoses. I think.
Yeah, it is not in real time. So there is registry for chronic health illnesses at home, but it's lagging like, 3-4 years, sometimes more in getting accurate data because there is not a digital intake into these clinics to really track them appropriately. So one, it's being collected in an inefficient way, and then it's also being collected is not as accurate because it needs a lot of manual work in terms of how they're tracking that data. So by the time you collect data for a year, 5-6 years has passed and it's not as applicable moving forward. So I think if the intake and tracking was digital as well, especially in public institutions, because that's where the bulk of patient care is. Ultimately, Barbados, we have free healthcare. So the bulk of the population goes to public institutions. Persons that access private care usually have insurance, but it's not like in the US where everybody has health insurance. Most people don't. So the public system really needs to incorporate these things more, because if small silos of us are doing it in the private sector, that's great, but it's not ultimately changing the medical care and the experience for the bulk of the population.
Right. Yeah, the funding, it's interesting. I think about, as a physician here in the United States, it's about access. And even here in the United States, those who have insurance and those who don't, right? I just had a patient last, no insurance. And because she didn't have insurance, she's presenting at stage 4. cancer, right? She
Yeah,
just was able to get some insurance, and it's been years, and here she is, right? So I think
yeah,
that whole question of access is not only something that you deal with in the Caribbean. We very much deal with that in healthcare disparities here in the United States. So
yeah,
forums like these are very helpful. I think about an earlier speaker who was very interested in collaborating and expanding access to care, utilizing and figuring out how these private-public partnerships, when it comes
yeah,
to infrastructure, where funding is needed, and you have another entity over here that potentially has those resources to assist with and
yeah,
meet those gaps. So again, events like this, I think, are very important, and this is not the end of it. So I'm looking
yeah.
forward to a lot of collaboration and ongoing discussion beyond just the event that we had today in recognition of International Women's Day.
Yes, I agree. I think without collaboration, we'll individually hit a ceiling that we can't go beyond. And not only just public private sector partnership, but even like within the Caribbean as a whole, the region does need to collaborate more. So each person isn't working on their own thing and not making the necessary headway, and then making collaborations with larger groups in other countries doing the same thing, where we share information and then, figure out ways to move things forward as effectively as possible to improve patient care all around.
Yes. Any other comments? Thank you. That was an excellent presentation. Definitely
Yeah.
sparked thought and conversation.
Thank you.
Amazing event. I just want to, oh, this is a great picture. Hold on. Get that. Smile. There you go. Nice. Okay, I'm just going to share my screen to close out quickly. Let's go here. Okay. I like this quote to close out this event. Research shows that women leaders often adopt transformational and participatory leadership styles, which are associated with higher collaboration, stronger organizational culture, and improved outcomes. Next steps, I want to thank all our speakers today. It's been a phenomenal event. We will be sending out a survey. We'd like to get your feedback, not only our presenters today, but also from our attendees. And some of those areas that we'd like to cover, how do we further support women leadership in digital health? We know that when women come together, things happen, and things happen for the collective. So we want to make sure we stay connected. We want to discuss, well, as Tori, I guess I should change the slide. We said women at the decision-making table. We are the table. And really exploring that idea as well. And mentorship, of course, very important, going from mentorship to sponsorship. And just giving you our contact information. Again, the recording of this event will be available on all the ISfTEH social media platforms, on our YouTube channel, and on our website. So again, I want to thank all of you. It has been such an inspirational day on so many different levels. There's so much going on, and we want to make sure that we are aware and connected as a global network, because when we're connected, we see improvements in health outcomes and access for all. So thank you. Have a wonderful weekend and enjoy International Women's Day, which is actually on Sunday. Celebrate yourself, celebrate another woman. Make sure you do something to take the time to recognize all that women are doing on an international basis. Okay, oh, okay. All right. Thank you. Thank you.
Thank
Thank you.
you.
Thank you, Lillian.
Bye-bye.
Thank you so much, everyone.
Phenomenal day. Phenomenal day.
Congratulations.
Oh, congratulations to
on
you.
the-
Inspiring, really inspiring.
Yes,
Thank
uh-huh.
you
Oh,
for the
really was.
opportunity.
Yes. Thank you.
Bye-bye.
Okay.
Thank you. Bye-bye.